A swarm huddle is a learning response from the Patient Safety Incident Response Framework, PSIRF. It is an opportunity to bring teams together after a patient safety incident or any event where there is new learning to be identified. It should take place as soon as possible after the event, ideally on the same day. It should be brief, 20 minutes, and can be undertaken in the environment that the event occurred to understand the environmental factors that may have contributed. The swarm huddle uses the SEIPS model to understand the system factors that contribute to safety incidents occurring. For more information, please visit the link in the About section under the video.
Afternoon, everyone. Thank you so much for coming to the Swarm Huddle. Have any of you been to a Swarm Huddle before? No. Okay, first time for all of you. Let's start with a quick round of introductions and then I'll explain what a Swarm Huddle is and then we'll get stuck in if that's okay. It shouldn't take more than 15 minutes or so. We don't want to keep you here all day. And I know a couple of you have come in on your day off, so thank you very much. My name's Hannah. I work in the governance team. I've been implementing the Patient Safety Incident Response Framework, so I was asked to come and help support this Swarm Huddle.
Hi everyone, I'm Charlotte, I'm the ward manager.
Hi, I'm Vicky, I'm the staff nurse on the ward.
Hi, I'm Jay, I'm clinical site manager.
Hi, I'm Sarah, I'm bank HCA.
Hi, I'm Louise. Was the consultant surgeon that was doing a ward round on the ward.
Lovely, thanks very much. So we just wanted to spend a little bit of time talking about John, who had a fall yesterday. So the purpose of a Swarm Huddle is a kind of get together of the team that were involved in a patient safety incident to try and identify if there's any learning. We want to look at the system and the way the system works, and we're not looking to blame individuals. And so very much we're looking at how our system is interacting and how that might have contributed to John's fall. And we're aware that patient safety incidents are inevitable, and particularly falls. They're not always completely avoidable, but I thought there was quite a bit of learning we could probably identify from this one, from the radar form, that would be helpful just to get the team back together and see if there's anything that we need to change off the back of that incident. Pleased to say that John is actually doing fine. He hasn't had any kind of adverse outcome from his fall. He's aware that we're meeting today to unpick any learning, and he didn't have any questions for us. And I know that you've already had duty of care, and so thank you so much for doing that. Okay, so I'm going to take some notes if that's okay, while we're just unpicking what happened. And those of you that were involved can just talk it through your involvement in the incident. And I will try and map that to the system factors that we think might have contributed towards it. And then we'll summarise by seeing if there's any actions that we need to take away from today. So Vicky, you were the nurse looking after him. Do you mind just giving us a bit of a summary of the incident?
Yeah, so John had recently been admitted to the ward, and I was, at the time of the incident, I was drawing up some IV antibiotics in the treatment room, and I assumed that the healthcare assistant was in the bay. And I was alerted by Louise, our doctor, who was doing a ward round, that John was found on the bathroom floor.
Okay, thank you. So Lou, you came across John.
Yeah, we were just walking past. We were seeing patients in the other bay and just walked past the door and heard a shout, and walked in and found him wedged in the bathroom. There was a lot of stuff in the bathroom. There was some commodes and some urinals, and there was just lots of stuff. And he said that he tried to pull the call valve but couldn't find it. And we tried to get him out. He was breathing, and we did ABCs, but he looked sweaty and clammy, and I wanted to check his blood sugar. As he said, he felt a bit lightheaded before he went down. But it was really difficult to find anybody. There was nobody else. There were no nurses around. Eventually found Vicky in that room behind the nurses' station. It was all sort of locked away.
In the drug prep?
Yeah.
Okay, fine. So Charlotte, you were the ward sister on the day. Do you want to just kind of set the scene in terms of what the acuity was like, what was happening on the ward, what else was going on?
So unfortunately, on the day in question, it was a typical crazy morning. I had come out of my office. I was supposed to be in a management day, but I'd come out to join the numbers, as we were 2 nurses down that shift, and also a HCA was also off poorly, so we were extremely short-staffed. In terms of acuity, we were full. We were for escalation, so we were at real max capacity. So at the time of the incident, I was actually in the bay at the other end doing a drug round. So I wasn't aware of what had gone on, but I was at the other end of the ward. I came in, can't remember the time now, I think maybe it was about 8:30, and I'd escalated to clinical site that we were obviously down 3 members of staff. I left a flu bleeps, but I wasn't able to get through to anyone, so I went and started the drug round, and then obviously things changed from there.
Okay, thanks very much. So Jay, I think you were clinical site.
Yeah.
Day. Do you mind just kind of filling us in at what typically happens with escalation in terms of staffing and stuff?
Yeah, so around 8:30 we normally have our huddle with the team. So obviously during that time we don't answer any phone calls. And after that I had noticed that you had to have a couple of phone calls from the ward. But when I went to return them, unfortunately I was then called to a cardiac arrest and ED, so I went there. In terms of staffing, we obviously tried to spread and starting out along across the whole organisation, making sure it's safe, and we saw some extra members of staff, but we really could.
Okay, thank you. Which Sarah probably brings us along to you. So you said that you were a bank healthcare assistant, so don't typically work on this ward?
No, I don't usually work on ward. I usually work in endoscopy or in outpatients or places like that usually.
Okay, fine, thank you very much. And this was your first time on the ward?
It was my first time on the particular ward, yeah.
And I presume that you sometimes get moved around?
Yes.
So you're used to that, but do you find that you tend to get good orientation when you go to a new ward? What does that feel like for you as a bank member of staff?
On that particular time, unfortunately, I'd missed the handover, so I wasn't aware of all the orientation of the ward, and sometimes that is quite stretched in terms of staffing and people being able to support bank staff coming onto the ward. I also wasn't aware that there was bay nursing going on, and I'd never done that before, so I wasn't aware of that either.
Okay, thank you. So bay nurse, it's not something that I'm overly familiar with because I normally work in maternity. What does bay nursing look like?
So it's a relatively new initiative, or well, I say we've been doing it for donkeys, but we're trying to reintroduce it. And the idea being that there is always a member of staff within that designated bay. So if, for example, even if you're in there behind the curtains with a patient, there is somebody in there who's got eyes and ears of kind of what's going on. The idea being that if you need to come out and do something else, that you almost tag team or pass a baton, lanyard, whatever, but between 2 members of staff, so that there's always someone in there. In theory, it works really well, and I think when you've got the right numbers of staff and you've got people in the bay, it does work. But I think, it can be quite tricky if you've got to go and do something else. But that's the theory behind it, and it's something that we across the organisation are trying to adopt.
Okay, thank you. So Vicky, you worked on this ward for quite some time. Are you familiar with the concept of bay nurse? Do you feel like it's well embedded across the ward?
Well, actually, I have only recently come back from maternity leave, so this incident happened on the day that I was doing a keeping in touch shift, whereas I should have been supernumerary, and so I wasn't aware about the bay methods.
I think we've rolled it out since maybe while you were off, actually. Yeah.
So I wasn't aware that that takes place.
Is that why your card didn't work then when we wanted? Is it?
So part of being supernumerary and being on these keeping in touch days is so you can get access to your IT and to your ID badges. So there was a delay with the blood sugar being taken because I hadn't done any of my training, and that's what happens by having I have access to the IT either. So it was quite stressful. It's very busy on the ward anyway, but having all of those challenges as well was very frustrating.
It sounds like it was quite stressful. And you said normally you'd be supernumerary and that was your first kid day back, but you was pulled off into the numbers because of the staffing problems. Okay, thank you.
It's absolutely not our idea. Yeah.
Especially on a weekend as well when numbers are slightly depleted. Yeah, okay. So it'd be really nice just to talk a little bit about John, if that's okay. So he hadn't been on the ward for very long. I wonder if you could just kind of explain what you knew about him and the handover that you'd received, and if we were aware that he was of high falls risk, whether that was known information or whether that was something that we weren't aware of.
So John hadn't been on the ward for very long, but he came up with a paper handover, and it was identified that he was a falls risk on there. If we had known about that, then we could have
maybe he wouldn't have gone to the bathroom.
He would, yeah, so he would have made sure that he was supported going out to the bathroom, but we weren't aware, so.
Do we have anything on the ward that identifies those patients that are high falls risk?
Yeah, so we have patients at glance boards, and when we have our safety briefing in the mornings, we identify those patients that are at a falls risk across the ward. So if we see anybody trying to get out to the bathroom, we can assist that.
Okay, but obviously that relies on you being informed that he was a high falls risk and that wasn't on its paper house. Let me know that. Okay. So we know that best practice should be a verbal handover that occurs by the bedside with the patient. What typically happens when a patient comes, crosses between wards? What does it normally look like?
And so the patient, my previous patient hadn't been discharged and the bed was empty. So the porter had brought up the patient with the notes, and we had orientated John to the bay.
Okay.
I think as well on that day in question, we were April 4, there was extreme pressure downstairs from the front door. So the usual process of getting patients into the bed and kind of making swift discharges is something that we're quite well adverse to. So yeah, there is a quick turnover on our ward, particularly on days like that.
Okay, thank you. And you talked about your safety huddles in the morning.
Yeah.
So what do they typically look like?
Yeah, so obviously we have the normal full huddle in the morning where all of the clinical information is shared, and then there's like a summary version that happens with the team or the bay that you're in, kind of identifying, like you say, those patients who are high falls risk, anybody that needs input from physio, AT, kind of recommendations about diet if they need a modified diet, etc. So all of those risk or critical information is shared amongst the team that are directly looking after that patient. It happens in the morning, and then we do the same again in the afternoon after ward round, etc., when things have changed. So there's that quick kind of short summary of what's going on at a glance within the day.
Okay.
Yeah.
Okay. And I presume, Sarah, obviously you'd been moved across and you didn't arrive in time for handover. So did you then miss that safety huddle?
I did, yes. Yeah.
I mean, not that would have changed things here because we hadn't been handed over the AIM as a high falls risk anyway. It'd be interesting to know whether or not the falls risk assessment had been done. So perhaps that's something that we could go away and have a look at. Okay. So we've looked a little bit around our tools and technology. The falls risk. Oh, Lou, you had mentioned something around the bath.
Oh,
it was environment.
so cluttered. So I know that space is at premium on the ward, but there probably needs to be something sorted out to make sure that bathrooms are accessible, and not just as a storage.
Yeah, using that one to store some of the overspills in pulp and stuff that we've had recently. But yeah, absolutely take your point. Yeah, all that leakage.
That's something that can probably be relatively easily rectified, but we'll come on to actions in a little bit. Another thing Lou, you'd mentioned was the call belt was out of reach.
Yes. So it was hooked up. There was a little hook by the side of the bathroom, and I think it was because it's so long on purpose. But it looked like it'd been hooked up maybe when they were doing some cleaning or something.
Okay.
Yeah, Lou mentioned this to me at the time after the event. I think, again, in that kind of swift turnover to get the room ready for the next patient, I know that my domestic team have been in there giving it a clean, but the usual checklist that's kind of on the back of the door to say the room was ready, all that sort of stuff was missing. So I wonder whether that was just either an oversight from cleaning and we missed it. So yeah, I think that was, again, in that essence of getting someone in there quickly, I can see why that was perhaps missed.
Okay. Thank you all. I think we've pulled quite a lot there already. Are there any key points that you think we might have missed? Or not discussed? Okay. So I think it'd be really nice if we could just spend a few minutes just identifying any actions that we think are appropriate for us as a team to take aware of, if there's anything that we think we need to escalate elsewhere, and also to think about where we want to share this learning and who's going to feed back to the patient or family. There's a couple of bathroom issues. So I think we've talked about sewerage,
The clutter out.
absolutely, yeah, and also the issue with the call belt being hooked up, and I know that happens in multiple areas across the hospital. Are you happy to Liz?
Yeah, I was domestic in the year. I'll pick that up with procurement in terms of stores of what we're storing, and also from the domestics. Yeah, absolutely.
Okay, brilliant, thank you. Jay, I'm just thinking about clinical site and obviously that period whereby you're in safety huddle and the process whereby you take bleeps but won't always get an opportunity to return because of other things that are happening. I wonder if there's a conversation that's needed to be had. I don't know if you think there's an action there that we could do just to communicate that better.
Definitely. I think obviously we know it's a protected time, but the assumption is we would do return those phone calls where possible, but we could do some more comms maybe just to make sure that wards do follow up and return contact us again if they don't get it.
I think that was a 4J when I've run before for help. Someone's always phoned me back, so I think I just assumed that someone would.
Yeah, unfortunately, we were told to caught up in another emergency.
And it's difficult when you're caught up in the numbers as well. You can't keep chasing it. But I think clarity around who the responsibility sits with, if they're escalating for help, would be really beneficial. I think there's something here around the lack of SBAR handover, especially handover at the bedside. But I think that is a bigger issue than just between perhaps this ward and the ward that this patient came from. So I'm going to propose that I escalate that to probably the matron team and also perhaps our site nurses, and have a conversation around what we can do to improve that, because it may be that there's other quality improvement work already going on and we can link into some of that. I don't know that we're going to be able to solve that right here, right now. I was thinking about your experience as bank staff that's moving around quite a lot. I'm wondering how we can improve that, both from your experience perspective, but also from the patient safety perspective. I don't know if either of you've got thoughts around that.
It's all right. Yeah, really sorry. That's not how we would like to induct our bank staff on the day of their shifts. There's, a proper process where you're supposed to have the tour in the unit and to kind of orientate yourself to the environment, where things are and all of those things. And unfortunately, I just didn't get to that. So I think definitely moving forward that process. And I know that's something that's being pushed by the organisation to try and make sure that process is much slicker and much more supported for that member of staff. So yeah, definitely a big piece of work there for me, I think, for making sure that happens.
Similarly, from our point of view, be responsible for ourselves as well. So just to make sure that when we do come onto the ward, that we try and seek out those relevant people to get that right information from before we start our day's work, really.
Do you know what? I've got a orientation pack that one of our student nurses did as a little quality improvement program recently, and I always forget that it's there. We should give it to you. So that's definitely something we need to push a little bit more around, just making sure that there's something there. I didn't have time to talk necessarily, but I could have. I absolutely think there's something there, definitely.
Yeah. Would you be able to link in with temporary staffing as well? Because I think it's going to apply to lots of wards as opposed to just ours. I think that'd be really helpful. And Vicky, your first day back reminds me of my first days back in maternity many years ago, and they are really stressful. I wonder whether there's anything we could do to relieve that stress, to make that a smoother process. What are your thoughts?
I think it would be good to have, because obviously I was off for nearly 8 years, so it would be really good to have some sort of welcome backpack, maybe, just to see what's been going on the ward. There's been lots of just because it's been lots to tell you just while you've been gone. So that would be really helpful, and some protecting time to make sure IT and badges are working would have really helped.
Yeah, absolutely. No, I think those changes, that reorientation back to the environment, isn't it? No, absolutely, and I think that's really important.
Are you two happy to put together on that action? That's good. Thanks very much. I think we've picked up quite a lot there. As I said, I don't want to keep you guys for too long. We just need to think about where we want to share this learning, and think about where else in the organisation this event could happen. So we've already thought about some of that temporary staffing, the stuff around SBAR bedside handovers, etc. The call bells being tied up, which is probably could impact the whole trust.
We won't be alone in that, I don't think so.
Yeah, I've definitely seen it before. I'm just thinking in terms of where we want to share this, the outcome of this swarm huddle.
So I guess for me, I could share this at our patient safety meeting that we have every month, which is chaired by our governance lead. So we can share that and kind of that learning within our service group. And then I guess that gets escalated to others. But definitely through that platform. I'll obviously close the radar incident and upload the documents from today, etc., into that, and also link back in with John and his family to say that we've met and what we've kind of talked about. I know they didn't have any burning questions, but just to reassure them that we've met and we've got some really good ideas to take forward. I'll do that if that's okay.
Great. Becky, you got a governance board on your ward?
Oh yeah, I do. Yeah, in my staff room. So I can update that there. And we share the instances that come through every month. So absolutely, I'll pop on there as well. Yeah.
Brilliant, great, thank you. And then I think the other place that might be useful to take it is the matrons meeting. So obviously your governance lead can link in with the service groups, but I think if we take this to the matrons meeting, that can think about where else we want to spread this association as they do to kind of tie that loop off. You've already said your feedback to John and his family, so thank you very much. Okay, I think that's probably it. Is there anything else anyone would like to add? No. Okay, I found that really beneficial, and thank you for bearing with some of those questions that I asked. Thank you all for participating. I think we've got some really clear actions there. I hope you found it helpful. If you're struggling in any way and you want to talk about any element of this incident, then please do reach out to your peers or to any one of us or to colleague support service. I'd be really happy to support you with it. But as I said, John didn't suffer any harm from the fall, which was good. Thanks very much.